Hello guys, welcome to EM Rounds. I wish all of my fellow colleagues all over the world a very happy emergency medicine day. And I'm thinking of taking an webinar for a long time, and I thought this is the best time for starting a webinar. And today's topic for the discussion is cracking the code, a ABG guided approach to hypoxemia. I'm pretty sure that all of us, the emergency physicians, are using ABG, I won't say ABG, blood gas analysis, left and right for evaluation of patients. And I'm pretty sure that most of us are using the ABG for the purpose of analyzing the acid-base status, but very seldom we evaluate for an hypoxemia. So I have done a much research on this hypoxemia or the literature review, and I have found some very interesting facts about evaluation of hypoxemia, and I thought I will share with you guys, right? So the discussion of this blood gas analysis will be in two parts, and the first part we will be discussing how does a normal ABG looks like and how to evaluate an hypoxemia in a systematic way, right? So what is a blood gas? So the human blood is regulated between a strict pH between 7.35 to 45, and it is regulated by a very complex mechanism which include the buffering system and also several compensatory mechanisms which include the respiratory and bicarbonate system, and they have maintained a pH between 7.35 to 45. The blood gas means you are looking at the blood at the dissolved gases within the blood, right? So you are monitoring the blood gases which is dissolved within and also the acid base status. So you can take the blood gas from anywhere from the body, right? So it can be from the artery which forms the ABG, it can be from the venous side which is VBG, and you can even take them from the capillaries from your tip of your fingers, which is known as CBG, which is very seldom used in emergencies, and it is used in pediatrics, especially in pediatric emergencies where you are it is very difficult to get a venous or an arterial line, right? So which one to choose when, right? So next question comes, when to take an ABG. I won't say ABG, blood gas analysis. I will come to that, why I have termed that BG, not ABG. So there are three situations where you have to take an blood gas. These are the only three situations where you have to take an ABG in an emergency or a BG in emergency. So there are acute presentations where a patient comes with an undifferentiated signs with abnormality in A, B, C, D, E. So if the patient is having severe respiratory distress, or patient is having hemodynamic instability, or he is having an altered sensorium which is undifferentiated or unexplained, or hypothermia, something like that, so you have to take an ABG to look for the acid base status, right? So next set of patients are an acute or chronic presentation where patient is having a chronic diseases which are prone for an acid base imbalance. For example, for in a patient case of a CKD, where your patient might present with a severe metabolic acidosis hyperkalemia if the patient have a missed dialysis, something like that. Also in patients who have diabetes and the patient comes to ER with high sugars and abdominal pain, you might have to take an ABG where the chronic disease which is in diabetes might result in an acute presentation of DKA, right? And there is very rare, uncommon but not so rare presentation where you might get an incidental finding when you take an ABG for some other causes, you are some other purposes, and you are getting an abnormal blood gas analysis. For example, the patient is on diuretics and you took an ABG to look for the creatinine immediately to look for, do a contrast study, and you are finding a severe metabolic alkalosis, maybe because of the drugs. Or a patient who have a respiratory renal tubular acidosis, where the patient comes to know the patient is having hypokalemia, and you are doing a ABG and you are showing a type 1 type 1 renal tubular acidosis, something like that. So these are the three presentations where you have to take an ABG. So there are two situations where you have to take a blood gas analysis. First thing is the oxygenation ventilation problem, where you have to take an arterial blood gas. In any other situation other than this oxygen ventilation problem, you can do a VBG, which is as good as an ABG. I will be discussing about the comparison between them later in the slides. So we'll have a patient here. So it's a 50-year-old male who presented to the ER with shortness of breath and hypoxia. And he is hemodynamically stable and his saturation in room air is 89. So what is the test that you should order? Yeah, this is ABG for sure, but ABG is quite a painful procedure to the patient, and sometimes it is a difficult procedure to the doctor who is doing the procedure, right? So there are several studies where they compared VBG with pulse oximetry saturation, and this is a recent study in 2023, and they have compared these both, and they have shown that if you see the saturation in the SaO2 in the arterial blood, and you are measuring the pulse oximetry oxygen, dissolved oxygen, and they have the similar interquartile range, and there is no much difference, and they are very accurate. And if you take a patient who's hemodynamically unstable, and if the saturation is less than 85, and they comes in the extremes of values where it is not specific. So the summary is, if the patient is hemodynamically stable and if the saturation is above 85%, you may not be need a ABG, where you can compare a VBG with pulse oximetry dissolved oxygen saturation, which is more than enough. If the patient is hemodynamically unstable and the saturation is less than 85, it is ideal to do an ABG, right? So you got an idea when to do an ABG. So I think only in severe ARDS or patient who is having cardiogenic shock, where you might have to get an ABG. In almost all other cases, ABG is as good as your ABG. So how to take an ABG, all of you know, I don't have to tell that. We have to do a modified Allen's test before doing an ABG. But several studies have shown that it is not necessary. And what if the patient is unconscious, where your patient may not be will be able to do a make a fist, right? So in an unconscious patient, what you can do in a place of Allen's test is you place the pulse oximetry over the thumb of the patient, and you occlude the radial artery, and you will look at the waveform which is still persisting, and you will do the same by occluding the ulnar artery. As simple as that, right? So there is no relative contraindications for doing an ABG. Any bleeding diathesis, any compromisation of skin barrier like infection, burns, or any surgery in the site, or severe peripheral arterial disease, or trauma to the hand, these are the relative contraindication. And very important thing is that you do not puncture where the artery should be. You should palpate, and you have to felt a pulse, then only you have to proceed further. So I'm not going to the procedure proper. What are the components of ABG? So the components of ABG are broadly divided into the measured values and the calculated values. So the measured values are the directly measured in the blood. These are mainly the pH, partial pressure of oxygen, and partial pressure of carbon dioxide. And the calculated values in the ABG are the bicarbonate and saturation. So remember that bicarbonate and saturation is calculated value, which is derived from the measured values of pH, PO2, and PCO2, right? So if you see the ABG, you can now go and see your ABGs. You can see there is a small c in front of this bicarbonate, CHCO3 and CSAO2. These are the calculated values, and all others are the measured values. So what is the importance of this? So I will come to this in the later slides. So I told you how they calculate this bicarbonate and saturation, right? So bicarbonate is calculated using the Henderson-Hasselbalch equation, where you put the values of pH and your PCO2 and you get a bicarbonate value, right? And saturation, what you get using the corrected CO2, the calculated values are standardized to the room temperature and at a room temperature. And if you calculate the saturation, that is SaO2, it is based on the partial pressure of O2. So if you see the graph, the standardized value goes to the red, where the all things are in equilibrium. So if you see the for a partial pressure of 40, the ABG will always show a saturation of 70, and for a value of above 90 partial pressure of oxygen, it always show a saturation of 100. So whatever you take an whichever patient you take, if the value is CSO2, then the value will be same in all patients for a particular partial pressure of oxygen. You got the point, right? So this is it. So there are several machines where you have co-oximetry, where you can get a measured saturation, which is especially used in carbon monoxide poisoning or with hemoglobinemia, where you can get a co-oximetric values of separate values of dissolved oxygen, and your the dissolved carbon dioxide, carbon monoxide, etc. Right? So these are the normal values. I'm pretty sure that all of you know that it is normal ABG values. The pH is 7.35 to 45, PCO2 is 35 to 45, and PO2 in room air is 80 to 100, and bicarbonate is 20 to 26, and saturation in room air in standardization is 95 to 100. And if you compare with VBG and ABG, except for your PO2 and saturation, where there is a very much higher difference of wide range of values, others have a very close relation or close value. So only in case of hypoxemia or abnormal oxygenation or ventilation, you have to take an ABG, right? So how do a standardization of ABG? So for an ECG, the first thing that you have to look for the demographics and standardization, right? You know that it is 2 large box tall and 1 large box width. Similarly, the standardization of ABG, how will you know whether the ABG that you have done is standardized or it is correct before you assessing the ABG, just like reading an ECG? So as I said, we told that the bicarbonate is the calculated value. So what you can do is you can calculate the bicarbonate using your PCO2 and pH, and you make sure that the bicarbonate that you calculated is in appropriation or is same as that of in your ABG strip. So what you can, the value or the formula is 0.03 into partial pressure of carbon dioxide into 10 to the power of pH minus 6.1. So the values for the pH minus 6.1 for each pH has been given. If you want, you can calculate using this formula, or you can you can calculate the bicarbonate using your MD calc also, right? So next comes the topic proper, approach to oxygenation and ventilation issue using an ABG. Here you have to take an ABG, there is no doubt. So ABG is a must. And why you have two values? One is partial pressure of oxygen, and there is a saturation or dissolved oxygen concentration. So why there is two values for assessing the oxygenation? Yeah, exactly. So the oxygen in the blood is dissolved in two forms. One is it is bind to the hemoglobin, and the saturated hemoglobin, which is interpreted as your SaO2, and the dissolved oxygen, which is only less than 7%, which is calculated in the form of partial pressure of oxygen. And remember, always remember that the ABG machine directly measures only the partial pressure of oxygen, not the saturation, right? And also you need an PCO2, partial pressure of carbon dioxide, which is also directly measured to look for the ventilation issue. So will you use SaO2 in an ABG to assess patients whether is the sample taken is an ABG or patient's oxygenation status? Except if the ABG is having a co-oximetric value. Otherwise, you should not use the saturation SaO2 in the ABG for comparing for assessing the patient's oxygenation. The pulse oximetry value, which is more than 85, will be more specific, specific than your ABG value saturation, dissolved oxygen saturation, right? So as we said, the normal partial pressure in room air is 80 to 100, and it reflects the true oxygenation status. So for a patient who's hypoxia, we having hypoxia, the value that you have to look at is the partial pressure of oxygen. And how does partial pressure, I told you the normal value at room air is 80 to 100, and the value of partial pressure of oxygen depends upon several things. It depends upon the altitude where you are staying. As the high altitude increases, the dissolved partial pressure of oxygen decreases, and also if you see, the partial pressure of oxygen also depend upon the inhaled concentration of oxygen. If you are the room air FiO2 is 21%, as the percentage of oxygen increases, the partial pressure of oxygen increases. There is a relationship between, so as I said, as the height, the altitude increases, the partial pressure of oxygen decreases. At the sea level, it is partial pressure of oxygen is 150, sorry, is 100, and that is 80 to 100, and as the height increases, it becomes reduced. Okay. So if you see here, what is the target partial pressure of oxygen that you have to keep in a patient? The partial pressure target for a person should be at least 60. If you see here, this is the oxygen dissociation curve, where you can see this is the point where the partial pressure of oxygen is 60, where the saturation or the dissolved oxygen concentration is maintained at a value of 90. As the value reduces from 60, there is a rapid reduction in the dissolved oxygen concentration. So there will be a severe hypoxemia in patients who have a partial pressure of oxygen less than 60. So the target should be, in any patient, the partial pressure of oxygen should be more than 60, where you can get a saturation which is more than 90. Clear? So what are you looking into? So there are several disorders associated with oxygenation. So one is increased oxygen, that is hyperoxia, and next is hypoxemia and hypoxia. So what is the difference between hypoxemia and hypoxia? So hypoxemia is reduction in the dissolved oxygen concentration, whereas hypoxia is the reduction of oxygen delivery into the tissue. There is a oxygenation problem in the tissue level, right? And other thing that we are looking is the hypo and hypercarbia. So what is hyperoxia? So hyperoxia is when the arterial oxygenation is more than 100 millimeters of mercury. And if you see the FiO2 and partial pressure of oxygen, there is a clear correlation. As I said, this is the room air. If the patient is given as FiO2 50%, the partial pressure of oxygen approximately comes to the 5 times your partial pressure of oxygen. That if it is 50 into 5, that is the partial pressure of oxygen should be at least 250 millimeters of mercury. So there is some concept known as relative hypoxia, where the patient is given a FiO2 of 50%, and if the patient is having a partial pressure of oxygen which is less than 250, the patient is hypoxic for that corresponding FiO2. You understand? If the suppose the patient is having a FiO2 of 40 and the saturation or the partial pressure of oxygen is 100, the expected partial pressure of oxygen for a 40% FiO2 is 40 into 5, that is 200, and the patient is having a relative hypoxia, right? As I said, for a 40%, the range is 200. For a 100%, so maximum partial pressure of oxygen that is attained at a sea level is 50, and it can go up to 2000 when you increase the partial pressure into 3 atmospheric pressure, which we usually do in a hyperbaric oxygen therapy, right? So what is the difference between hypoxemia and hypoxia? As I said, the hypoxemia occurs in the blood where dissolved oxygen is low, whereas hypoxia occurs at the tissues. Hypoxemia can be classically classified using the blood gas analysis, whereas hypoxia is usually indirect findings where patient might have a low saturation, which may be interpreted in the end organs, where when the reduced oxygen occurs, there is anaerobic metabolism where lactate is produced, right? Hypoxia may be lead to hypoxemia, whereas such as in case of so hypoxemia may lead to hypoxia, not always. Hypoxemia, what happens when there is an hypoxemia, there is changes in the oxygen dissociation curve so that the tissue hypoxia is prevented, right? So for example, in COPD patient, the patient is having an hypoxemia but the end organs are clear, whereas hypoxia can exist without an hypoxemia. For example, in cyanide poisoning, what happens is there is the oxygen, dissolved oxygen is adequate, maybe higher when you give oxygen, but in the end organs, because of the mitochondrial damage or the destruction, the patient cannot utilize the oxygen. So these are not interchangeable, right? So how will you assess the severity of hypoxia? So there are several techniques that can be used to assess the severity of hypoxia or hypoxemia. So the one technique is using the PF ratio, which is classically used in ARDS, and another classical or another assessment method is the alveolar arterial gradient, right? So the PF ratio, so how will you calculate the PF ratio? You are doing a fraction where PaO2 is divided over the partial pressure of oxygen. So for a PF ratio for a normal patient who is in a room air will be the 100 bar 0.21, which is around 500. So PF ratio is around 500. So this is classically used in your ARDS patients. So where you compare or you classify the severity into normal, mild, moderate and severe. If it is more than 300, it is considered as normal, or if it is 200 to 300, it is considered as mild ARDS. 100 to 200 is moderate, and less than 100 considered as severe ARDS. It is specifically used in ARDS patients. Also, it can be used in normal patients who are having a high oxygen requirement, right? So the next mode of assessing the severity is based on the alveolar arterial oxygen gradient. So you can see in this diagram, this is the alveoli where you can see the oxygen within the partial pressure of oxygen within the alveoli. This is the partial pressure of oxygen within the artery, and there is a gradient through which the oxygen is diffused along the membrane into the artery, right? So for a specific age, there is a specific cutoff for this alveolar arterial oxygen gradient, which is arbitrarily calculated using the equation age divided by 4 plus 4. For example, for a 40-year-old male, it will be coming between 40 divided by 4 plus 4 is around 40, right? So the alveolar arterial gradient is the difference between the partial pressure of oxygen within the alveoli minus the artery. So remember that the high alveolar arterial oxygen gradient means there is lots of oxygen in the alveoli but not a lot in the artery, whereas a normal or low indicates there is a good diffusion between the membrane and there is no abnormality in the membrane or within the alveoli. Just remember these 2 points, right? So how will you assess the gradient? So for that you have to calculate the alveolar partial pressure of oxygen. The equation here is this one. You don't have to memorize this equation, but you have to know that you require an FiO2 value and require an PaCO2 value to look at to calculate the alveolar partial pressure of oxygen, and you can simply put it in the MD calc, right? So let's calculate the gradient here. So for a 40-year-old male who is a case of pneumonia, and he is on 5 liter per minute oxygen, and the ABG values are given here. The partial pressure of oxygen is 60 and carbon dioxide is 40. So how will you calculate? You use the equation. For a 40-year-old male, as we calculated, the partial pressure, the alveolar arterial gradient should be 14 or low, should not be more than 14, right? So if you calculate using the formula, so how will you calculate the FiO2 here? The oxygen is 5 liter per minute, right? So for the room air oxygen saturation is 21%. For every 1 liter there is an increase of 4% of oxygen. So 21 plus 5 liter into 4, that is around 41. So FiO2 is 41 and the partial pressure of carbon dioxide is 60. And as you calculate, you can get the gradient as 140 and the normal expected is 14. So there is a high alveolar arterial gradient, right? So there is a diffusion problem because of pneumonia here, right? So how will you evaluate the hypoxemia using your ABG here? So you can have, there are 5 major etiologies that results in hypoxemia, that is low oxygen content in the blood. So first one is the ventilation perfusion mismatch. If there is an abnormality in the ventilation part, if the alveoli is collapsed or alveoli has destroyed, or there is blood flow abnormality like in pulmonary embolism, it results in hypoxemia, right? And next comes the shunt. So I will discuss the shunt later on. So the shunt can be intracardiac and extracardiac, and if there is abnormality in the diffusion membrane, especially in case of interstitial lung diseases or ARDS in the early stages where the fibrosis of the membrane happens, can cause hypoxemia. And next comes the hypoventilation, where there is a neuromuscular dysfunction or any toxins which results in hypoventilation, also can result in hypoxemia. And the next comes the low FiO2, that is if you have a low inspired oxygen level, such as in case of a closed room or in case of a high altitude situation, right there. So we can see here the shunt physiology is the most common etiology of hypoxemia, and the shunt physiology can be, as I said, it can be extracardiac or intracardiac. The intracardiac physiology, as you know, the cyanotic heart disease like VST, tetralogy of Fallot, such situations, you can have mixing of the blood and there will be shunting of oxygenated blood into the deoxygenated blood. Here if you see, this is a normal alveoli where there is no shunting. Almost all the RBCs are, there is a dissolved oxygen of a partial pressure of 114, which is normal, whereas there is an abnormal alveoli where the blood is not only partially oxygenated and the further blood is shunted distal to the pulmonary veins, right? So ventilation perfusion mismatch we have seen, that is if it is a block, there is abnormal ventilation perfusion mismatch, or is any destroyed lung, it results in abnormal ventilation perfusion. And if there is an interstitial lung disease or ARDS where there is a thickening of the membrane, results in hypoxemia, where classically you can see the high alveolar arterial gradient, right, and high altitude. This is the 5 causes of hypoxemia. Remember these 5 causes, right? So there are the several etiologies of each causes. So high altitude sickness, hyperventilation, such as in case of OSA, any opioid poisoning or neuromuscular disorders, diffusion disorders like ILD, and ventilation mismatch you can see in a destroyed lung in case of COPD or pulmonary embolism or fibrosis. And shunt, as you see, the anatomic include the ASD and VSD, and physiologic include the shunting because of the severe abnormal shunting of the blood. Okay, so how will you approach the hypoxemia here? So for any patient who, the first step in ABG analysis should be the evaluation of hypoxemia, where you have to look initially at the history and examination, and you look at the hypoxemia based on the partial pressure of oxygen, and you look at the severity of hypoxemia either using the PF ratio and the alveolar arterial oxygen gradient, and finally look at the PaCO2 for the hypoventilation. So how will you assess the ventilation perfusion mismatch? What does these 5 questions in a ventilation perfusion mismatch? Suppose you look at the pulmonary embolism here. So the history will be suggesting of pulmonary embolism or asthma, that you can get specifically, that I don't have to explain much more. And for sure there will be a low partial pressure of oxygen, and the PF ratio will be obviously reduced because of the partial pressure of oxygen. PF ratio will be low here, and the alveolar oxygen gradient, for obviously there is, which will be increased, and the PaCO2 is variable. And remember that the hypoxemia might be partially corrected with the oxygen but might not be completely, right? And the partial pressure of carbon dioxide is variable based upon, if the patient is having a good ventilatory efforts, the patient may hyperventilate and results in respiratory alkalosis. If the respiratory drive is low, it results in respiratory acidosis, or it can be a pure complete compensation also, right? So how does shunt looks like? In shunt, the history, you can get history of any VSD or any tetralogy of Faraday physiology, and hypoxemia will be there, and there is, it will not be corrected using the oxygen. That is the major difference between shunting and your ventilation perfusion mismatch. In shunting, in the case of escape also, if you are giving oxygen, it might not be corrected with your normal oxygen. You might have to give a higher PEEP so that the shunt physiology is overcome, right? Like in case of sympathetic crashing acute pulmonary edema, and here also the shunt causes diffusion defect, which results in increased gradient, and PaCO2 may be normal or decreased. And diffusion disorder, here also it partially corrects with oxygen, and PF ratio will be decreased, and alveolar oxygen gradient will be, as usual, will be increased, and the PaCO2 might be variable. And in high altitude, can have the history of mountaineers, and it corrects, especially with oxygen, there will be hypoxia, which will be corrected because of the low FiO2, and the PF ratio is decreased, and alveolar oxygen gradient will be normal because there is no abnormality within the diffusion between the membranes, right? And look at the PaCO2. PaCO2 may be variable based upon the patient's ventilatory status. In hypoventilation, like the history will be like patient having bradypnea, poisoning or snake bite, or neuromuscular disorder, and here also the hypoventilation also corrects with oxygen, and there will be low PF ratio, and will be normal or low because the ventilation is the problem affected, the membrane is intact. So in hypoventilation and in altitude, the alveolar oxygen gradient will be normal. In all the other 3 conditions, you will have a increased gradient, and especially only in hypoventilation you can get a partial pressure of oxygen, carbon dioxide, which is increased, causing hypercarbia, right? So as I discussed, you can see in the altitude and hypoventilation, it fully corrects with oxygen, and there will be a low alveolar arterial gradient, whereas in shunt physiology, oxygen will not correct the alveolar oxygen gradient. You might require a high PEEP, and in other diffusion mismatch, partially corrects with oxygen, there is a increased alveolar arterial gradient. So these are the things that will help you to differentiate the etiologies here, right? And remember about the partial pressure, the relative hypoxia based upon the FiO2 partial pressure correlation. So the next part we will discuss about the ABG analysis, the types of ABG analysis in the next part. Thank you so much.